Good morning or good afternoon, depending on what time you're listening to the record. My name is Mariam Hamandi. I'll be talking today about an article that's about a case report of a tongue ulcer. This was actually published in 2019, which is not that old. First of all, a 57-year-old patient attended the oral medicine or went to an oral medicine department complaining of a painful ulcer a painful ulcer on the tip of the tongue that was developed like 3 to 4 weeks ago, and without any history of a trauma. He described a pricking sensation and an increased soreness at the tongue tip area upon touching. And this is a picture that's showing off like what he's complaining of. Going through the patient's medical history, they found out that he suffered from tuberculosis 40 years ago, and there was a complete recovery reported back then. As for the extraoral examination, it was carried out and everything was within normal limits. The intraoral examination, they found out that the ulcer is 0.7 centimeters or 7 millimeters round ulcer on the tip of the tongue. It's characterized by granulomatous center and whitish well-defined border with a slight elevation as shown in the picture. The base of the lesion was firm in consistency and on digital palpation. And then they did radiographs and laboratory examination. The panoramic radiograph showed no evidence of bone involvement. Laboratory examination, they did the CBC, the complete blood count, and it was within normal. Serological test was made for an HIV or hepatitis C, and they were both negative. So based on the clinical examination, they ended up with the following differential diagnosis. First of all, they thought of like it's a major aphthous ulcer. It's either a major aphthous ulcer, a traumatic ulcer, granulomatous disease, or an infection. We may rule out traumatic ulcer, as we said in the history. He didn't have any trauma history. They actually, according to those, they decided to treat this ulcer with a topical mouthwash with a mixture of amoxicillin 1 gram and prednisolone 30 milligrams in 500 milliliters of distilled water. This was actually used for 7 weeks with careful instructions to avoid possible stimuli. And they also used triaminocolone acetonide 5 milligrams. This was actually injected into the lesion twice for 2 months. After using this treatment, the ulcer started healing, but it didn't improve totally, or it improved, but it didn't completely disappear. So they decided to go for a biopsy in order to rule out malignancy, and they ended up doing an incisional biopsy. They did an incisional biopsy under local anesthesia. They did a histological examination, and the histological examination revealed the following: numerous epithelioidal cells first, and multiple Langerhans giant cells. Ziehl-Neelsen staining demonstrated acid-fast bacilli. And as we can see in A, we can see the oral mucosa with intense granulomatous inflammation. In picture B, we can see the epithelioid cells with Langerhans giant cells. And in C, the presence of an aggregate of small red rods of mycobacterial organisms. So based on the histological findings, they ended up with this oral ulcer is actually diagnosed as lingual tuberculosis. And so they ended up referring the patient. They actually referred the patient to a nematologist, a pneumologist, in which they did the acid-fast bacilli, like acid-fast bacilli cultures were positive for M. tuberculosis complex. They did a chest computed tomography as shown in this picture, and it showed destructive findings with consolidation and fibrothorax in the right lung and the formation of cavitary lesions with clustered centrilobular micronodules in the left lung apex. In picture A, we can see the coronal view, and in B, a horizontal view. After 2 months of the drug therapy, the oral ulcer disappeared, and they did the AFB, which is the acid-fast bacilli culture, and shows no growth of the tuberculosis in 4 weeks. And they actually ended up with a follow-up for 9 months, and there were no complications. We can see this slide showing us, like, from the beginning until the end. It actually started in December 2017. No, it actually started like 40 years ago. He had a TB history, and then in December 2017, January 2018, he attended the clinic for a radiographic examination and a laboratory exam, and everything was done, and because of the shock complaint of a painful ulcer, they ended up giving him a wrong medication, although it worked a bit, but it didn't. But the ulcer didn't disappear. And they ended up doing an incisional biopsy in order to rule out malignancy. They found out that it's actually a lingual TB. They referred him to the pneumologist, and after that, the ulcer ended up healing in October 2018. They did a follow-up check, as I said, after 9 months, and everything was fine, and the patient had no complaint. So, as a conclusion, we as dentists are the first healthcare professionals that frequently encounter various oral lesions. So it's important to understand various oral manifestations of TB. It's very important, although it's like rare to see like oral manifestation of TB, but it should be included in our differential diagnosis for persistent oral lesions when diagnosing patient with a history, especially with a patient of history of TB, even though the evidence is rare, as I said. And in the case that I was talking about, it was difficult to differentiate it, actually, because the patient had a history of TB like over 40 years, but this shows that it is possible to have M. tuberculosis incubated in his lungs and reactivated later on. So it doesn't matter how many years it's been there and if he recovered or not, but we always need to think of it, although it's rare. And thank you for listening. This is the reference that I used if you would like to see the article. Thank you.